Cardiologist in the CMR unit of the Euromedical General Clinic to talk about CMR and arrhythmogenic cardiomyopathy.
Good morning.
Good morning.
Can you see my talk?
Not yet. Yes, now.
Okay. So I would like to thank as well Professor Mavrogieni and the organizing committee for this kind invitation. I will talk about CMR and arrhythmogenic cardiomyopathy. Arrhythmogenic cardiomyopathy is a genetic heart muscle disease whose pathological hallmark is the fibrofatty tissue replacement of the ventricular myocardium. It was originally termed as arrhythmogenic RV dysplasia or cardiomyopathy, but it also, due to post-mortem studies and genotype-phenotype correlation studies, and of course the progress of CMR has shown that it may also involve the left ventricle. So the new term follows the concept that arrhythmogenic cardiomyopathy affects both ventricles with some phenotypic variants characterized by a parallel or predominant involvement of the LV. It leads to predisposition to fatal ventricular arrhythmias, mainly in young individuals and athletes, and its common first presentation is sudden cardiac death, making its early diagnosis crucial. So for the first time in 1994, world experts, Professor William McKenna and other experts developed structural, histological, ECG-based arrhythmic and genetic criteria. They had, however, poor reproducibility and low specificity, especially regarding family history. And there was no quantitative or objective definition of abnormality. This led to the revision of this criteria in 2010, where we have a quantitative imaging reference value, including sex-specific volume indices, and the combination of segmental abnormalities and RV dysfunction or enlargement was required, leading to a higher specificity. And CMR gained significance in ARVC evaluation in this way. So why is the role of CMR in RV evaluation important? It is a safe, non-invasive procedure independent of acoustic window. We have no exposure to ionizing radiation. We have a high 3D resolution and optimal visualization of the RV, which is not always the case with the echo. We have high accuracy and reproducibility, and we can assess the chamber size, volumes, global and regional function, shunt quantification, and tissue characteristics, all in one study. All these make CMR the gold standard for RV evaluation. But how did we become aware of the LV involvement in ACM? Thanks to post-mortem studies, as this one, which is one of the largest ones, the investigators examined the hearts of 2,002 patients with sudden cardiac death and diagnosis of ARVC. And they found out that in 70% there was a biventricular involvement, whereas in 17% there was only left ventricular involvement. And interestingly, 80% of the patients were previously asymptomatic. But the LV involvement was known long ago. Again, from the group of Professor McKenna, they found out in 2008 that some patients with desmosomal mutations presented with arrhythmias of LV origin, and there was subepicardial or mid-wall LGE corresponding to fibrofatty replacement in histopathology. Interestingly, again, 50% of the patients had been previously misdiagnosed with viral myocarditis, DCM, hypertrophic cardiomyopathy, or idiopathic VT. So the task force criteria lacked sensitivity for identifying the wide phenotypic spectrum of ACM, although it could assess very nicely the phenotypic spectrum of right ventricular involvement in ACM. And we have this new criteria in 2020, which tried to incorporate and diagnose all the LV phenotypic features. And the key upgrade is, of course, the tissue characterization findings of CMR. with LGE. And we see here the key role of CMR in the Padua criteria, both for right ventricle and left ventricle. And the diagnosis of borderline, possible, or definite arrhythmogenic cardiomyopathy is dependent on the more than one morphofunctional and or structural criterion for both ventricles. But we can see that if we have no RV abnormalities for the left dominant arrhythmogenic cardiomyopathy, one LV structural criterion is not enough. Because we have very often overlap of this disease with other heart muscle diseases as DCM, sarcoidosis, or myocarditis. So in order to say that we have a left dominant, to have the definite diagnosis of left dominant arrhythmogenic cardiomyopathy, we need a positive phenotyping, positive genotyping for an ACM specific gene mutation. And we see here that the genetic defects, according to the ventricular involvement, most pathogenic mutations affect genes encoding structural proteins involving the organization of intracellular junctions. Most frequently, these are cardiac desmosomal proteins, and ACM-causing mutations have also been found in non-desmosomal genes as phospholamban, filamin C, desmin, and lamin, which are associated with other cardiomyopathies such as DCM or neuromuscular CM, and may lead to these overlapping phenotypes. And we have the new guidelines, the latest guidelines with a new term of non-dilated left ventricular cardiomyopathy, which includes individuals that up until now may have been variably described as having DCM without LV dilatation, arrhythmogenic left ventricular cardiomyopathy, or left dominant ARVC, or arrhythmogenic DCM, but often without fulfilling diagnostic criteria for ARVC. This is a new phenotypic description of cardiomyopathies, and the key role of ventricular myocardial scar assessment using CMR imaging is again addressed. And here we can see the examples of non-dilated left ventricular cardiomyopathy phenotypes and their etiological correlates. And of course, given the increased awareness of the importance of diagnosing these LV phenotypes, these guidelines were followed by an updated task force consensus report, where the great change is that we have this ring-like pattern of LGE in CMR in the left ventricle as a major criterion. This is a very interesting study which tried to differentiate ACM and DCM LV phenotypes. We see that ACM has lower LV volume and mass, less depressed LV ejection fraction, and greater amount of late gadolinium enhancement. It is namely about a hypokinetic, non-dilated and fibrotic left ventricle compared to patients with DCM. Late gadolinium enhancement predominantly affects the inferolateral segments in ACM, whereas the septal segments in DCM. And in ACM, the LGE appears as a stria pattern that more frequently affects the subepicardial layers compared with the spotty, patchy pattern and mid-myocardial myocardial location of DCM. Although not included in the guidelines or in any task force report, really, we should always look for this distinguished, this very important hallmark, the fat infiltration in CMR, the so-known rat bite sign. And here we can see a subtricuspid dyskinesia. We can see this known accordion sign on the left, on the right ventricle. with fibrofatty replacement in the LGE images. And on the right, you can see the so-known so-called butterfly apex, which is not pathological, and it is a normal variant. And as we can see that as we move more superiorly, it disappears. Again, for the right ventricle, T1 weighted images on the upper panel and late gadolinium enhancement on the on C and D. You can see the fibrofatty replacement of the right ventricle. This is a very recent study which tried to assess the arrhythmic risk prediction in non-dilated left ventricular cardiomyopathies and the role of overlap with ACM. And they found out, the investigators found out that the patients who had definite or borderline criteria for ACM, according to the latest task force, were at increased risk compared to the patients with possible or no criteria, suggesting that these ACM patients represent a subpopulation of non-dilated left ventricular cardiomyopathy patients deserving closer surveillance. And we can see they found out that independent predictors of sudden cardiac death, ventricular fibrillation or sustained VT was late gadolinium enhancement higher than 9% of the LV mass, and the patients who had also fatty infiltration as long with late gadolinium enhancement higher than 9% were at the highest risk. The recommended CMR study protocol includes, as always, cine images, but we need RV dedicated images as well. T1 weighted images, it's very important, as I mentioned, for the fatty infiltration. T2 weighted images assessing edema in cases of acute presentation of the patient, and of course late gadolinium enhancement, including right dedicated images, right ventricle dedicated images, and flow CMR, because we have we may often have an RV dilatation, and we should always assess QPQS as well. And the first case is about a female, 24 years old, with many episodes of syncope during dancing. She was she's a dancer. Her ECG showed negative T2 waves in V2 to V6. The echo showed a normal left ventricular ejection fraction, but an RV dilatation and hypokinesia. She was referred for CMR. And we can see here, on the left is the short axis stack. The left ventricular ejection fraction is normal, but we can all agree that the right ventricle is a little bit ugly. When if I'm allowed to say, we have a hypokinetic right ventricle, and the T1 weighted images on the bottom, normal and fat sat. We're not sure if we have a fatty infiltration on the RV free wall. It is difficult to evaluate it on for the right ventricle, because the wall is thinner than this on the left ventricle. In any case, we've proceeded with the late gadolinium enhancement. And we see, surprisingly, that we have a mid-wall enhancement of the left ventricle of the basal septum. We can see it here very nicely. And so we have an ACM with biventricular involvement. The genetic testing showed a PLN mutation, and the due to the high risk of the gene and the syncopes, she underwent an ECD implantation. And I'm going on with the second case, about a female 20 years old with no past medical history. She was presented in the ER with acute chest pain, respiratory infection since 3 days. She had COVID infection 3 months ago, and head troponin level was very high. She had a normal ECG with an incomplete right BBB, and the echo was completely normal. We can see here the cines. low normal, maybe the left ventricle, 52% ejection fraction, mild effusion, pericardial effusion. And surprisingly, we see these late enhancement images with this ring-like pattern in the short axis and subepicardial to mid-wall fibrosis in the whole left ventricle. The so-called ring-like pattern. She was genetically tested. She had a desmoplekin mutation. Her Holter ECG was stable for a long, about 1 year. She was started on heart failure medication. She was advised to restrict from any endurance sport or competitive sport activities. But due to an NSVT in the Holter 1 year after diagnosis, she underwent an ECD implantation as well. And here I would like to address with this study, and Mrs. Tsumani mentioned it as well, that we must know that these desmoplekin carriers, gene mutations, patients, they have often this hot phase presentation, who they can present as clinically as myocarditis, and we will not know that they are carriers of a mutation or that they have an ACM if they do not go in the CMR investigations. And this third case is about a male, 48 years old, with a history of PVC since 12 months, but lately polymorphic, and SVT is not responding to any medication. He had known 3-vessel coronary artery disease with PCI and drug-eluting stent implantations. He had COVID infection 6 months ago, and the echo showed an LV dilatation with low normal LV ejection fraction. We can see it here. Dilated left ventricle, mildly dilated left ventricle, and here are the CNEs. And we can see that he has extensive late gadolinium enhancement in the subepicardium. And this is, and mid-wall in the septum as well. And this is the T1 image, which shows this fat infiltration, this rat bite sign here, where it represents in the LGE sequence, we see also that we have LGE, enhanced late gadolinium enhancement. He was tested and had a filamin C mutation. He was, of course, on a heart failure medication, and he underwent an ECD implantation as well due to electric instability. So the phenotypes and clinical presentation of ECM are more complex than previously believed. The latest guidelines reflect a movement toward a dynamic phenotype-anchored approach, better suited to capture the complexity of cardiomyopathy. CMR has, of course, a key role in the diagnosis of ACM, especially in left ventricular dominant ACM due to its unique ability of myocardial tissue characterization. And we should always know that the clinical history, genetics, and multimodality imaging should be all integrated in the diagnosis and risk stratification of ACM. I would like here to address as well that these patients are not at risk of developing heart failure. This is not the case, and we are not really, if I'm allowed to say, interested in showing of whether the LV ejection fraction is lower or where is the ejection fraction. These patients are at great risk for sudden cardiac death, and we should also always bear that in mind. Thank you very much.
Very much, Dr. Christidi. Very useful clinically messages, especially the last one, that regardless of the ejection fraction, the risk is quite high. I would like to, in patients with arrhythmogenic cardiomyopathy, especially with the hallmark of left-sided arrhythmogenic cardiomyopathy, I mean the LG ring-like pattern, which is actually observed in the majority of desmoplakin or filament C DCM genotypes. I'm just wondering if we have to implant a defibrillator as soon as we see a ring-like pattern and desmoplakin on filament C without waiting for some arrhythmic events. Because in the next 3-5 years, those patients with ring-like scarring, 50% of them develop experience adverse outcomes, death, arrest, ICD therapy. What do you think?
Yes, it's a very it's a hot topic at the moment.
Yes,
I think
yes.
because this is a new era in cardiology. I'm not sure we know all the genes till now, but we are at a good point with the genotype phenotypic correlation and the CMR. We have no big studies. These are not the patients with hypertrophic cardiomyopathy, which is well established.
Right.
We have this 15% of LGE in the guidelines. But when we see this ring-like pattern, we have no patients. Ring-like pattern doesn't mean 9%. Ring-like pattern is 20% of LV mass and higher. So we have a very high burden of scar. We have quite arrhythmogenic left ventricle. Of course, we know that there are some genes that are worse than others. Lamine, desmoplakin. I think it should be, as always in medicine, as Professor Mavrogianni mentioned, it should be also clinical context correlated. And the whole history of the patient. We must see the gene, we must see the CMR, we must know the family history, and of course the patient's life. Is he an athlete? Is a dancer, as I mentioned? And it's not well established, but we may not only, we are not allowed to depend only on the LV ejection fraction as for the rest of the patients in cardiomyopathy, because most of them do not go under 45%. They will never reach these 30%. So we must be very careful and I'm afraid we must be more aggressive with ECD implantations. This is the only group of cardiomyopathies where we must, if I'm allowed to say, be more aggressive with ECD implantation. The risk is very, very high. The risk of sudden cardiac death is very high.
That's right. And another important issue is in the hot phases of arrhythmogenic cardiomyopathy, mimicking myocarditis, overlapping with myocarditis actually, before having the definite diagnosis of arrhythmogenic cardiomyopathy. Some centers, as I pointed out some time ago, with ring-like pattern and hot phases of arrhythmogenic myocarditis give immunosuppression, because in the hot phase of myocarditis or arrhythmogenic cardiomyopathy, if we've got desmoplakin, we've got a high incidence of recurrence of these sort of episodes, and sometimes they are arrhythmic episodes. Anyway, these are, those two things, arrhythmogenic cardiomyopathy with ring-like and desmoplakin without electrical manifestations. It's a controversial issue if we have to implant defibrillator before arrhythmic events. Anyway.
Yes, thank you, Stamatis. Thank you very much for the excellent and highly interesting talk, Dr. Christidi. I would like to ask you if you diagnose extensive fibrofatty replacement in the RVI apex. Is that an issue for considering subcutaneous ICDs in ARVC patients? You know that there may be issues regarding the safety of ICD electrodes or leads in the re-apex, especially in the case of ARVC and the fibrofatty replacement that is taking place there.
Yes, that would be very helpful to go with the other type of ECD implantation. As I mentioned, RV is very tricky for late enhancement assessment, and most of all for this fatty infiltration due to its thin wall. But yes, that would be also of great interest, the apex of right ventricle and how we proceed with the ECD implantation. And I would like also to say, to respond to the comment of Mr. Avramopoulos, it's very interesting. I had a patient very recently with his AC, with the ring-like pattern. Her T2 relaxation time was sky high. And the 6 months later, she's waiting for the gene result, but 6 months later, she still has high T2 values. So this is an area I have found no studies regarding T2 in these patients. But they might have an ongoing myocardial inflammation, which we are not aware of because we don't put them in the scanner in order to see the progress.
Mm-hmm. Very nice information. Michael, would like to take over?
Thank you very much, Stamatis. Thank you for the excellent talk, Dr. Christidi. We're very good in time, and we proceed with